I'm C.T. Tan. I'd like to talk about the neurocognitive and quality of life aspect of epilepsy surgery. Whereas up to 60 to 80% of patients who undergo surgery for partial epilepsy will become seizure-free, about 25 to 40% of those individuals will also experience an post-operative decline in memory, language, or some other aspect of cognitive function, the most important being memory. To predict the post-surgery decline of memory, material specificity has been the traditional concept. This indicates that the left and right temporal lobes process different types of materials, verbal on the left side and non-verbal on the right. Whereas the verbal memory on the left largely holds true, recent studies have shown that the spatial memory is not so strongly lateralized and requires the function of both temporal lobes. There is also evidence for intratemporal specialization of verbal memory, with the medial temporal lobe handling the unfamiliar words that requires encoding, the lateral temporal lobe handling the storage of information that has been stably consolidated, and the perirhinal cortex, the gatekeeper of the two components. For prediction of memory deficits after surgery, the most important risk factors are surgery on the left or dominant side, preoperative good memory function, and absence of atrophy in MRI, both the latter indicating removal of functional tissues. In epilepsy surgery, it is also important to manage the expectation of patients and the caregivers of the long-term outcome, the so-called quality of life issues. In fact, seizure freedom post-surgery can impose its own problem of adaptation for the patients, the so-called burden of normality, especially for those whose seizures started early in life with limited education and life skills. Nevertheless, the strongest factor to improve quality of life long-term is seizure freedom, with the patients being operated having improvement in employment, driving, reduced medication, as well as mortality.